Hello, I'm Dr. Robert Varnam,
Hello, my name's Dr. Richard Jenkins.
and we're going to tell you about the new primary care trigger tool for measuring harm in general practice.
If we could start thinking about some of the questions that might be pertinent at the moment in general practice. How many of our patients are harmed every day or every year? How many of us know the answer to that question? And if they are harmed, which areas in our practice are causing the harm? What's causing the adverse events that our patients are suffering? And if we come to answers for these questions, what changes could we implement and make to make things better in the future? And if we make changes, are we confident that they're an improvement? Are we confident they're going to make things better?
As you'll see, the primary care trigger tool helps to fill in some of the gaps in our current answers about these questions. And I'm going to illustrate how it might serve us by looking at a Venn diagram. Of course, any of us in a practice would like to be able to be assured that we're measuring and taking notice of every patient safety issue that affects our patients. So we'd like to get the biggest possible data set about patient safety that we can lay our hands on. The thing is that it stands to reason, and our experience and research bears it out, that actually any one source of information about patient safety has strengths but also limitations. And so if we're going to want to get the most comprehensive view of safety in the practice possible, we're likely to need to use a variety of different measures of patient safety. At present in general practice, we're doing quite well at using staff to provide information about safety, in particular with significant event analysis and event reporting. Some practices are using surveys as well, so something like the MAPSAF culture survey is very useful. Some of the things we're not doing so much of, which could be very useful for us, are exec walkarounds and observation of practice. New methods of using staff's intuition and experience and observation of patient safety in order to identify areas we should be working on. We make some use of patients for providing information about patient safety, but perhaps we leave them out a little bit. We relegate complaints to being something different from patient safety, whereas actually we could be using patient comments and ideas and suggestions to provide some information about things that staff may not notice. The area that we're not using at all at the moment is this bottom one, and it's metrics. At the moment we have no measurements of patient safety for general practice. Hospitals have several, but in primary care we don't currently have any, and this is where the primary care trigger tool comes in, because the primary care trigger tool will help you calculate an adverse event rate for your practice. The theory of a Venn diagram is really held with the expectation that there's some overlap between these sources, that there's certain redundancy. But actually the research evidence so far suggests that actually there isn't any overlap between these three types of information source about patient safety. In other words, if you want to be addressing everything that matters to the safety of your patients, you really do need to be using as many information sources as possible. Two other distinctions which I think this diagram helps us be a bit more clear about. And the first is that, broadly speaking, the items above the line are useful for understanding patient safety. So if you want to do root cause analysis, if you want to dig down into the the details of why a particular event happened, these are useful methods for doing it. However, they are not measures. And so, for example, we've all had the experience of identifying a problem through SEA, making changes in the practice, but then having no idea a year later how much of an improvement we've made in reducing that risk to patients, because staff reporting is not a metric. By converse, the metrics listed below here are ideally suited to measuring safety. They're quantitative tools, but they're not so good at providing understanding, so you can't do root cause analysis using a metric. So actually, in order to be getting the most appropriately comprehensive measure of safety, we need to be using things above and below the line. And finally, there's another distinction, which is that, broadly speaking, those things within this dotted red line focus on harms, actual outcomes for patients, whereas the things above tend to focus much more on errors. It's not an absolute distinction, it's a tendency only, but if we're more clear about these, we can first of all stop abusing some of the things that we're currently using, like expecting staff reporting to measure. But also we can identify where we need to bring new information sources to bear on answering those questions that Richard identified about patient safety.
So if we go back to our initial questions and think about how confident we are in general practice at the moment in answering them. In your practice and in your day-to-day work, how many patients had an adverse event last year? I'm sure we could all have a guesstimate, but how many of us actually know the answer to that question? And the harm that our patients are suffering as a result of care, where are the common areas? Where do we need to focus our attention? And if we've been working over the last year, more than that, on changes that we can put into practice, and most people try and improve their practice on a regular basis, how do we actually know that the changes we've been making over time have reduced the incidence of harm, have made things better? And we think the primary care trigger tool will answer those questions for you. So how do you work a trigger tool? The primary care trigger tool is looking at patients over the age of 75 years. So the first thing is to use your electronic medical record and list all of your patients aged over 75. That list then needs to be randomised so that we're sure that we're getting an honest appraisal of the safety within the practice. All the patients have an equal chance of being included, and we're going to measure across the board. And we're going to look at a 3-month time window of care. So we look back over 3 months and review the notes. How many notes you do depends on the size of your practice and your resource level, but we'd advocate between 25 and 100 every month. Smaller practices struggle to do 100, but we wouldn't suggest you do less than 25 because you need a certain size of patient selection in order to make the adverse event rate and your run charts useful. And finally, if you do pick a patient, don't select that same patient twice in one quarter. What we'll do with this slide is go through a step-by-step approach to how we do our case note review in the trigger tool methodology. And we'll start by saying, well, in our practice, for our size and our resource, we're going to select 50 patients every month. And the trigger tool methodology is a 2-step process. The first is looking for triggers, and the advantage and benefits of the trigger tool is that this doesn't have to be done by a clinical member of staff. And we actually advocate that this is done by someone in the practice who is perhaps clerical or office-based. You can be confident that this is okay because the triggers are unambiguous. They're there as a proxy measure of harm or to identify patients who are more likely to come to harm, but there's no subjective reasoning to be made about the triggers. They're either there or they're not. It's a yes or a no. And so anyone can do this first stage. So if we take our 50 sets of patient notes that we've randomly selected, our clerical staff will work through them and they'll look for the triggers. For example, in our case here, 30 of the 50 patients have no triggers found, and that's the end of their case note review. The 20 that were left now need to be collected and given to a clinical member of staff in the practice, and we'd suggest that would be a GP or an advanced nurse practitioner, somebody with diagnostic skills, because what they need to do is look at that trigger and then review the 3 months of notes and reason if there is an adverse event linked to the trigger, iatrogenic harm events, and by that we mean harm events caused by the delivery of care to a patient. So we've got 20 patients we look through, and 10 of them have no adverse events, and again that's the end of their case note review. The remaining 10 had a total of 12 events, and from that you can work out your event rate by dividing the 12 events by the 50 patients that we started with. Because we're measuring regularly on a monthly basis, we can plot the adverse event rate against time on a run chart, or in this example as a SPC chart. And that has various benefits. it answers your question, how many patients are harmed. Gives you a rate of how many patients are harmed over time. And not only that, when you put in a change, as you can see here in the blue, annotate it on your run chart or your SPC chart so that you know where in time you made that change, and you can see if what you've done has made an improvement. And as you can see on this chart, you put a change in change 1 and the rates come down and stay down over time. So you can be confident in your statement that we made a change to answer a problem and it's reduced our harm event rate. The trigger tool does more than give you a rate. It answers the other question we brought up at the beginning. Which areas of patient care are causing the most harm? And the triggers are set into various modules, and they're written along the bottom of the slide there: medication, general care, patient transfer. And the methodology allows you to say, well, if we're going to make changes, where do we need to focus our attention? Where do we need to prioritize our resource? And in this case, we'd suggest that medication, general care, etc. would be somewhere to focus your attention first. And the end of life, general care modules, although important, maybe you'd prioritize at a lesser degree.
The primary care trigger tool is one of a growing suite of trigger tools developed by the NHS Institute for Innovation and Improvement. There's already one for acute hospitals, and we're currently working on trigger tools for mental health, paediatrics, community hospitals and community nursing. The primary care tool was developed in partnership with 32 practices across England, selected to represent the widest possible diversity of practice types and geographical and demographic variation. These practices undertook 4,500 casenote reviews, which allowed us to analyse 1,400 adverse events which were detected in patients over 75. What's interesting is that 25% of these adverse events resulted in hospitalisation or permanent temporary harm or death, which is really quite high, and it provides assurance that the trigger tool is detecting things which genuinely matter. But the other interesting thing is that of these 1,400 adverse events, anecdotally, it appears that none of them had been reported to either the SEA system in the practice or to a local PCT or the NPSA's reporting and learning system, which does support the idea that the trigger tool is adding something different, qualitatively different in terms of the patient safety risks that it detects. We've had an independent expert academic review of the results from this, which has helped us to refine the trigger tool and to leave only those triggers which are highly specific for harm, because obviously the benefit of the two-stage trigger tool methodology is greatest when you've got triggers that have the greatest likelihood of detecting adverse events. And so this new primary care trigger tool, which is now able to be launched publicly, has an 81% sensitivity for adverse events, which is very encouraging and certainly performing better, for example, than staff reporting, which has probably less than 5% sensitivity. And it takes roughly 4 minutes per patient to do a casenote review using the trigger tool. I'm going to show you the modules which are included in the triggers. And these are the unambiguous proxy indicators which your clerical staff can review the notes looking for. So things in medication, things in general care, thromboembolism, patient transfer, pathology results, end of life, and key diagnosis. And what you'll see is, firstly, that these cover a fairly broad range of aspects of patient care. They look like things likely to be associated with harm, either because they're an indication of high-risk care or a vulnerable patient, or because these are things actually known to be associated with harm itself. The other thing you can see is that they are straightforward. They're very simple, and any member of the practice team could be entrusted with the job of looking for these in the patient's notes.
So what I'd like to do next is give an example of what a trigger is and what an adverse event is, and we'll use warfarin and bleeding as an example. On the laboratory module of the trigger tool, an INR greater than 5 is considered a positive trigger. As Robert was saying, these are unambiguous things, so a member of your clerical staff will look through the notes and it's a yes or no. Is the INR greater than 5? Yes or no. So we'll say that it is. The patient's got an INR greater than 5. Many clinicians, GPs and nurses will say, well, surely that's a harm event because the patient shouldn't have an INR greater than 5 and it's indicating substandard care. And whilst that may be true that quality care you'd hope wouldn't produce high INRs, most patients with an INR greater than 5 do not come to any harm. Many just have to change a dosing schedule or miss a couple of days of their warfarin, and the number itself is just that. It's giving you the INR, and often the patient is fine. So the INR is greater than 5. It's a positive trigger. That patient's handed down to the advanced nurse or the general practitioner who's going to do the next stage. And what they're looking for then is specifically adverse events linked to that trigger. So on reviewing the notes, in the 3-month time window you're looking at, you're focusing your attention, and that's the other reason that trigger tools are rapid and you're able to do a significant number every month. So the GP or the advanced nurse has a look through the notes, and you're looking for something that clinically is reasonable to be linked with an INR greater than 5. So something that would be reasonable would be a bruise or a hematoma or a bleed. And the picture on the right shows you a retinal bleed. So this patient was over-anticoagulated and they've come to harm as a direct consequence of the care they received. They've had an adverse event. And it doesn't matter if it's an error or not, we're measuring harm adverse event rate. Insertion of a catheter or having a catheter in situ is another trigger. Again, it's unambiguous. Your clerical staff will look through the notes, catheter, yes or no. And insertion of a catheter is often good care and appropriate, but sometimes results in unwanted effects to the patient. And a catheter-associated UTI would be an adverse event. The clinician would look through, the positive trigger's been handed down to them, and looking through the 3-month time window, if you see a UTI, then you could reasonably link that back to the catheter. Now, a lot of people think that catheter-associated UTI is something that is one of those things, but we know that with certain processes of care, patient safety and in this case catheter-associated UTI can be reduced. Similarly with non-steroidal anti-inflammatory medicines, we know that they're often appropriate and they're often very helpful for patients, but we also know that they have risks and they have unwanted effects, and you need processes in place to protect patients from it. So the catheter-associated UTI is an adverse event. It's counted, whether there's an error or not. The catheter insertion may have been entirely reasonable, but we're measuring the harm rate to patients over time.
And this is an example of the primary care trigger tool web form in which you can enter your casenote reviews. This is available to anyone in the NHS. It's a secure system that allows you both to enter your casenote review data and to get your results in real time. So plotting your run charts of the adverse event rate and taking a look at the bar chart to say where are most common harms occurring. Both can be done on this system. And you'll see here, once you're logged into the system, that you can get your clerical staff to be looking for the triggers for this patient and just ticking yes or no. And then when it comes to the clinical review, you do the same thing for that patient. And we encourage people, if you find an adverse event, to rate the severity of it. And the web form shows there's a category system rating from D all the way through to I, which allows you to get a bit more information about the harms that you're detecting, and certainly for prioritising activity in improving safety, that's quite a helpful thing. Lastly, there's a comment box. People quite like using that as a quick note to self when they find an adverse event, just to describe what it was that actually happened. The next version of this web form, which is expected out quite soon, will also allow you to record the location of the adverse event, because obviously sometimes you'll pick up something which occurred in hospital or in community nursing care, for example. And while that matters, and we should be taking note of it, you may not want to plot it on your personal practice's rate of harm, because it's hard for us to improve it. And so the trigger tool form will allow you to note that. The trigger tool portal requires registration both at a personal level and for your practice, and that's partly for added security, but it also enables you, for example, in one practice to have 3 or 4 people who have a login that allows them to get into the same set of data. So you can do that with a personal login, so you don't have to share your favourite personal login with your members of staff. You can each of you have your own personal login, all of which takes you to your practice's data and your practice's trigger tool forms. So on visiting our website and going to the trigger tool portal, it asks you to log in or register to access the content. And it begins by presenting you with a personal user registration form. Obviously, if you already have a registration for our website, you won't need this step. Once you've filled in that personal registration form, you'll receive a confirmation email from the system, usually in much less than a minute. It's often a matter of seconds, but does slightly depend on your email system on the day. And then you're able to visit the website again and now log in as yourself. Added benefits of doing that is you can sign up for our newsletter. You get access to much more content on the website as well, in terms of our downloadable guides to improving healthcare and quality as well as safety. Personally, I always recommend people immediately visit my profile and change their password. The system will start by giving you a randomly generated one, which is usually impossible to remember. So do feel free to go to my profile and you can update your password there. And then when you return to the Trigger Tool portal, you're logged in as yourself, but now you need to link your personal registration with your organisation. And as you see on this form, it allows you either to register your organisation from the scratch, or if you're not the first person in your practice registering, to link your personal account to your practice's account. And this box here, this search box, allows you to search for your practice, and every practice in the country is listed on here, so you will find yourselves there. It does give you the option of registering to use other trigger tools. I don't personally know why you'd want to register to use the paediatric or the acute trust one, but you've got that option there if you want to. And then when you've got your personal account and your organisation account for the practice, you come to the front page of the trigger tool and you can either do a casenote review or you can view your charts. You'll see you can do other things on here. You can add an annotation, so if you make a change, as Richard was describing earlier, you can mark that on. You can look at the data history and some other things you can explore at your leisure. So let's look at the option of doing a casenote review. It takes you to this form, as you'd expect. If you choose instead to view the data, you get a graphical representation of your run chart, and you can explore many other things on here as well. Particularly helpful is the opportunity to export your data. So if you didn't just want to view this on screen, you can export this to your own spreadsheet and record it the way you like. And you'll see as what it's recording for you. In red is your adverse event rate, and then on top, the orange and the green lines represent your control limits. So these are two standard deviations away from your mean, and that's the way of knowing the significance of changes that you achieve. So we hope that very brief run through primary care trigger tool has been helpful for you.
And we'd encourage you to register with the website and start doing the primary care trigger tool in your own practice, measure adverse events and start improving the care that your patients receive.
And you'll see on our web address there are links to information about our other training programs for improving patient safety and quality and productivity in NHS care, and a lot of resources there. We'd encourage you to have a look at those in more detail. Thanks very much.
Goodbye.